Hi everyone, welcome back to Journal Club on Facebook Live video in Psychiatry Network. I am just waiting for Dr. Kimchi to join us. For those of you who have been watching, we're actually winding down the videos. We just have, this is the fourth to last one, so after today we have 3 more videos and then we're all done. And I was thinking, if you guys have any other ideas for how the group could be useful for you, please let me know. I'm open to new ideas. If you would like some variation of this journal club idea, we can certainly work on that going forward. I just want to know kind of what you would like. So let me just see if he is starting. And yeah, we'll get going. So tonight is a geriatric psychiatry topic that we were supposed to do earlier in the schedule, but needed to reschedule, so we're doing it tonight. So hope everyone's well, and if you are able to, just feel free to say hi. I always like seeing who's watching. All right. Oh, there we go. And we're right now, and we'll get going.
Hi.
Hi there.
Hi, can you hear me?
Yeah, how's it going?
Okay, great. Good, how are you?
Good. So thank you for joining us tonight.
Sure.
And I will start off by reading Dr. Kimchi's bio, and we'll get going after that. So Dr. Kimchi is a board-certified geriatric psychiatrist on faculty at Rush University Medical Center. There he serves as Associate Medical Director of the Section of Geriatric Psychiatry, Associate Residency Training Director of Psychiatry, and Medical Director of Emergency Psychiatry. Dr. Kimchi's clinical and research interests focus on issues of decision-making capacity and dementia care. He has authored several textbook chapters on cognitive disorders, behavioral disturbances in dementia, and decision-making capacity. He completed his psychiatry residency training at the University of Maryland and Sheppard Pratt, and his geriatric psychiatry fellowship at Johns Hopkins University in Baltimore, Maryland. He subsequently joined the faculty at Johns Hopkins before relocating to the Chicagoland area. Dr. Kimchi is a fellow of the American Psychiatric Association and serves on its Council on Medical Education and Lifelong Learning. So thank you very much. And,
yeah, of course.
Yeah, feel free to get started.
Sure. Thanks so much, Christina, for inviting me, and It's nice to see you again. So I'm very excited to talk about this subject. Dementia is something that's near and dear to my heart. It's a big part of my training as a psychiatrist, and the idea of biomarkers in terms of either clinical or research utility is something that really is where the field of psychiatry and geriatric psychiatry is going. So I think it's really important. I'm glad that ABPN decided to include this article and this subject within the pilot study. So I think without further ado, what we're going to be talking about is the clinical utility of biomarkers in dementia. I think first we're going to talk about what a biomarker is and what are the different types of biomarkers that are currently in use. Then we'll discuss where biomarkers can be used either clinically or in research but are not currently in use. We're going to focus on 3 major neurodegenerative disorders, and these are the most common neurodegenerative disorders, and those include Alzheimer's disease, Lewy body disease, and frontotemporal disease. So I think we're going to start off by talking about what is a biomarker. As it mentions in the article, a biomarker is something that can be measured either objectively and can also be used as an indicator of either normal biological or pathological processes. It can also be used to evaluate whether a pharmacological intervention is therapeutic or not. They talk about what an ideal biomarker is, and I'm going to expand it a little bit, but first I'm going to talk about what they describe. They talk about a biomarker that is ideal is one that's both reproducible, is stable over time, is widely available, and is clinically relevant. I'm also going to add to that it should be cost effective. There's no point to have a biomarker that is thousands and thousands of dollars, particularly if it's not going to be clinically relevant or really add to the diagnosis or treatment. The other thing to keep in mind is the biomarkers really should have some significance, relevance, and utility in the management of your patient. I often tell my patients, yes, there are these tests out there, but it's not necessarily going to change my my management of your loved one or of you. And if that's the case, a loved one would have to decide: are we willing to spend $5,000 or even $500 on a test that won't necessarily change my management? Again, if they're thinking about a research study, then it may be relevant, and in those cases, research studies often pay for the tests. But in a purely clinical practice, it doesn't always change your management. So I think we need to keep in mind that in terms of dementia, we use biomarkers to help detect pre-symptomatic pathological changes, as well as predict decline or predict conversion from between different parts, different clinical states of a syndrome. So for instance, if we take Alzheimer's disease as one example, Alzheimer's disease is now categorized into 3 different stages. There's a preclinical stage. There is what was called mild cognitive impairment stage, and then there's the dementia stage. And so Alzheimer's disease is not the same thing as dementia. It is a cause of dementia. It's the most common cause of dementia. But to keep in mind, that first stage that I was describing, the preclinical stage, is a stage where there's nothing that we can detect either on paper or functionally that would help us determine that this patient has Alzheimer's disease. So what we have at our disposal are certain biomarkers. So when it comes to preclinical diseases, that can help us. Again, it can also help predict decline. There are some biomarkers that help predict how quickly somebody will decline from one stage into the next or between different stages of dementia. We also, again, use biomarkers to help monitor disease progression and then response to treatment. So there are several major categories of biomarkers, and these are talked about in the study that are currently used clinically or in the diagnosis of dementia. And those tend to include CSF or cerebrospinal fluid, as well as imaging modalities. While it would be great to be able to use either blood or urine biomarkers because they're cheap, they're easy to access, they don't require significant interventions such as lumbar puncture, they're not currently available for routine clinical use at this time. So that's something that I really want to hone in and make sure that we all recognize that blood and urine biomarkers are not used clinically at this time. That being said, dementia remains a clinical diagnosis. So the reason I bring that up, again, goes back to the fact that we're only using these tests to confirm what we're already suspicious of clinically, or we're used to help raise our, so again, we're using this to help raise our suspicion that what we're seeing clinically is in fact what is actually going on. And that's something that really was driven into me from day one of medical school, which is that we use laboratory tests, we use imaging to confirm what we're detecting on history and physical. It's no different here in terms of diagnosing dementia. So it helps us with the diagnostic accuracy of individuals with cognitive decline. I think most geriatricians and geriatric psychiatrists like myself would recommend brain imaging of some sort in the majority of patients who were working up for dementia for the first time. Usually that includes either CT or an MRI. I tend to favor an MRI. I know most of my colleagues also favor an MRI. It's more sensitive at assessing for vascular damage, at white matter changes, and also can also be used for detecting changes in more obscure, oh, hi, Monica, more obscure dementia syndromes such as prion diseases, where we're looking at spongiform and gliotic changes. The other thing that's interesting that I use MRIs for is that sometimes a specific pattern of brain loss or atrophy can reflect the specific pattern of neuronal loss, but that's not always there's not always a one-to-one correlation. Often you'll see individuals with florid dementia with almost no changes on MRI, and vice versa. You might see somebody with significant changes on MRI, yet while their MRIs show significant changes, clinically we don't really see evidence of florid dementia. We might see mild dementia. That being said, these imaging techniques can be used to help differentiate between different types of dementias. So for instance, if we saw atrophy in the hippocampus, we may start leaning more towards Alzheimer's disease rather than frontotemporal disease. So the next part of the study went into functional imaging, and that includes things such as PET scan or positron emission tomography, as well as SPECT. Those are the two that I would say are most commonly used, and between those, I tend to use PET more often. I think that is what my colleagues also tend to use. So we also use at times dopamine transporter scanning. We use those when we're thinking about things such as Parkinson's disease dementia or dementia with Lewy body disease. So those are looking at dopamine in the brain. We also want to keep in mind that there's fMRIs. fMRIs are often used in research to help measure the alterations between regional blood flow. I'm going to spend a little more time talking about PET scans because these are probably used most clinically hey Megan, of all of the different imaging modalities aside from MRI and CT. So when it comes to PET scan, there are a couple of different tracers that we can use. One looks at fluoridated glucose, so that's FDG. Another one looks at amyloid in the brain. So it's essentially it's tagged or it's radiation tagged amyloid. We use the former, the FDG, when we're trying to differentiate between Alzheimer's disease and frontotemporal disease. Based on the pattern or the uptake or the lack of uptake of glucose in the brain, we can help look at different patterns. Based on those patterns, we can help differentiate between Alzheimer's disease and frontotemporal disease. In fact, that's one of the few studies, aside from MRIs and CTs, that are actually FDA approved and that Medicare will fund. So Medicare will pay for an FDG PET scan if it's specifically used to differentiate between Alzheimer's disease and frontotemporal disease, as opposed to amyloids. Yeah. And so again, you have to use that very specific criteria that rule out Alzheimer's disease versus frontotemporal disease, frontotemporal dementia. On the other hand, amyloid tagged PET scans are commonly used in research. Sometimes we use them clinically. However, they're very expensive. They can range up to about $5,000 or so, and they're not covered by Medicare. So we use them in very specific cases, which I think I'll discuss in a little bit. I'm going to move on to the fluid biomarkers, and those are specifically CSF. So traditionally, we use different countries have different countries in different states in the United States have different theories on whether or not to use CSF as part of a standard workup of dementias. So for me specifically, I don't tend to use them. I find them pretty invasive. Usually, again, dementia is made, the diagnosis is made clinically. We also have other available biomarkers to use. So I try not to put somebody through a spinal tap, particularly if a patient is already has reached advanced levels of dementia. There's no point in putting that person through agony. I mean, the idea of trying to get consent from either the patient or family caregiver is pretty challenging. There are ethical dilemmas about whether to put somebody through that kind of process when it's not necessarily going to be of high value or utility. Mm-hmm. Again, different countries have different thought processes behind whether or not to use CSF. I believe in the UK, which is where this study was based, I believe they do use CSF more than they use in this country, but don't quote me on that, please. We often use CSF to help differentiate malignancies or rapidly degenerative dementias, rapidly progressive dementias such as CJD. Or we use them for individuals who are immunosuppressed. Again, if we're thinking about a possible cause like meningitis, encephalitis, if we're concerned about more bizarre or uncommon causes of dementia syndromes. Again, usually this should be guided based on the clinical picture. So if you know that a patient is immunocompromised, you might be thinking about a spinal tap at that point. If you know that if you have a sense that this patient has rapidly progressive dementia and you've ruled out other causes, you probably want to get a spinal tap pretty quickly in order to make a definitive diagnosis. So with rapidly progressive dementias, we're looking for the classic 1433 protein. We're also looking at elevations of total tau and to phosphorylated tau. Again, these are more specific reasons for the spinal tap. So in terms of blood and urine, this is just moving down on page 1427. Blood and urine, again, they'd be very advantageous if we could use them, but unfortunately, there really aren't any biomarkers that are blood-based or urine-based at this point that we can use clinically. There are a couple of different reasons for that that they highlight in the study. Some of them include the fact that by the time that something passes through the blood-brain barrier, it often is existing in such small quantities, or it's diluted to the point that it's really hard to detect that in the blood. Sometimes proteins can be, sometimes different biomarkers might be carried on proteins in the blood, and then again, more challenging to actually detect it. And then there's also the problem in terms of laboratory analysis. This also goes back to one of the issues that I have with CSF studies, is that there really aren't any hard and fast cutoff points for these biomarkers. So if a lab tells me, oh, this patient has low A beta 42, what does low mean? One lab is going to have a different definition of what low is versus another, and there really aren't any set guidelines about, well, if it's this low, then this person has Alzheimer's disease. If it's this high, then it's less likely. And that's also true for blood and urine biomarkers. There is a supplementary table in the online version of this PDF that demonstrates blood and urine biomarkers that are currently in development, but again, are not in clinical use. So now we're going to talk specifically about Alzheimer's disease, then we're going to talk about frontotemporal disease, and then about Lewy body disease. And not surprisingly, the article focuses mostly on Alzheimer's disease for a couple of reasons. One is that it is the most common cause of dementia. It's the most common neurodegenerative disorder, and therefore we also have the most data to support biomarkers and the most research that's done on individual biomarkers in dementia in Alzheimer's disease. So the background for Alzheimer's disease is that neuropathologically consists of amyloid plaques as well as neurofibrillary tangles that contain tau. There are other proteins and other things that are involved in Alzheimer's disease, but classically we think of the amyloid hypothesis. So again, the presence of amyloid plaques as well as the presence of neurofibrillary tangles containing tau. So a lot of the biomarkers are based on those different, on both plaques and tau. There are some autosomal dominant forms of Alzheimer's disease, and those usually involve one of three genes: the presenilin 1, presenilin 2, or the amyloid precursor protein. But overall, they only account for about 1% or less of all causes of Alzheimer's disease. So if you're fishing for a genetic mutation, you're likely to come up with an empty net. What we have now is we have what are called GWAS studies. So those are genome-wide studies, which are looking at much smaller genes that are implicated in the development of Alzheimer's disease, that each of them have a very small effect. So for instance, if you have an autosomal dominant, if you have presenilin 1, presenilin 2, or the APP mutated gene, then you're essentially guaranteed to get Alzheimer's disease. You may not see the phenotype of Alzheimer's disease within your lifetime because it may take 80 or 90 years before it develops, but you're essentially guaranteed to develop Alzheimer's disease, as opposed to in the GWAS studies where each individual gene only counts for a very small portion of the makeup or the cause of Alzheimer's disease. But if somebody has enough of these mutated genes, then it raises the risk that they might develop Alzheimer's disease. So each one in and of themselves has very little potential, but together they have more potential. But let's focus on non-genetic causes of Alzheimer's disease, because for the most part, most of the cases that we'll see are sporadic. So there are 5 different biomarkers that we tend to use in Alzheimer's disease, and these 5 are actually incorporated into the new Alzheimer's disease diagnostic criteria. And so those are divided into 2 different biomarkers. There's the amyloid pathology, and there's also So biomarkers of amyloid pathology and biomarkers of neuronal injury. So those that are including tau. So in terms of amyloid pathology, we think of low CSF and low amyloid beta 42 in the CSF, and we also think of abnormal tracer retention on amyloid PET imaging. In terms of neuronal injury, we think of there are three different biomarkers, and those include elevated CSF tau and elevated phosphorylated tau, as well as hypometabolism on FDG PET, and atrophy of the temporal lobe and parietal cortex. There's a really good table on page 1428, it's table 2, that goes through these biomarkers. It also goes through some of the criteria that we use to determine possible versus probable Alzheimer's disease. I think it's also important to keep in mind that so often we have mixed pathology, and I actually consider mixed pathology to be the rule rather than the exception. So the idea of having a pure Alzheimer's disease, or for that matter, pure vascular disease, pure Lewy body disease, is very rare. So what it means is that we're going to see pathology. We might see low CSF A beta 142 in diseases other than just Alzheimer's disease, such as in Lewy body disease. In fact, Lewy body disease and Alzheimer's disease often are comorbid. So the next thing I think that I'm going to talk about is using structural imaging to help as a biomarker. So, the thing about structural imaging is that it's great if we see global atrophy, especially if it has disproportionate or symmetrical involvement of the medial temporal lobes, including the hippocampi. That's great. If we get that, it helps to, I wouldn't say seal the deal, it's certainly not, but it definitely raises the likelihood that what we're seeing is Alzheimer's disease. But it's certainly not specific. It's sensitive but not specific. The issue is that we often don't see that on MRI. I would say most of the cases that I clinically determine that a patient has Alzheimer's disease do not show significant atrophy of the brain, and they certainly don't show regional atrophy, such as disproportionate involvement of the medial temporal lobe. If you are looking for that, I would suggest that you use an Alzheimer's disease type, that when you're asking a radiologist to read the MRI, you're being very clear in terms of what you're looking for, and say, please evaluate for temporal lobe, for hippocampal atrophy, but you're not necessarily going to see that all the time. So in some studies that they mentioned, it was they were able to differentiate Alzheimer's disease from dementia with Lewy body disease, as well as from vascular cognitive impairment. There was a good sensitivity and specificity in that study. That being said, again, the presence or absence of, or the presence of medial temporal lobe atrophy itself is not going to be able to, you're not going to be able to differentiate Alzheimer's disease from Lewy body disease based on that, because there's such an overlap between those two neurodegenerative diseases, and because they often go hand in hand or are found comorbidly. We can see, if we see progressive atrophy of the parietal lobes or the occipital lobes, we're starting to, again, differentiate frontotemporal disease from Alzheimer's disease. So Alzheimer's disease, we classically think about temporal parietal regions, and frontotemporal disease, we think about frontotemporal regions. But again, if you're really caught between those two diseases, I would suggest an FDG PET scan over just an MRI. It'll be more sensitive for looking at hypometabolism. One of the reasons that happens is we theorize that that you can see changes in glucose uptake way before you see the actual atrophy of those parts of the brain. There are some indications to use structural imaging when it comes to posterior cortical atrophy. We might see changes in the occipital region. They have a great image of that on page 1429. That's the figure 1. I highly suggest that you see that in a color form. So if you can see, bless you.
Excuse
if
me.
You can see sure. If you can see the actual PDF, it's better than on a printed version, where you can see changes both in terms of they go through an MRI of somebody with posterior cortical atrophy as well as a matched control. Then they show an FDG PET scan. An FDG PET scan of the same patient and control, and they also go through and they're also looking at what is this? And they're also, I believe, looking at at a Fluor beta Pyrrhus scan, if I recall. Yeah. So there are some indications, again, if you're thinking about posterior cortical atrophy syndrome. Again, your clinical judgment really should drive which test you're going to use and whether you're going to use any tests in general. The next thing we're going to talk about is cerebrospinal fluid. So levels of A beta 142 is thought to be one of the key pathological forms of amyloid beta in the brain tissue. It tends to be reduced in individuals with Alzheimer's disease, and it also is correlated with brain amyloid plaque load. So how much amyloid is actually in the brain. So because of that, it's considered one of the 5 biomarkers that we can use to raise somebody's likelihood of Alzheimer's disease from probable to possible. Again, if that's important clinically, sure, go for it. If that's important in terms of research, get it done. If you don't think it's going to change your management, whether you're able to diagnose possible versus probable, I wouldn't suggest getting that CSF test to begin with. And the other reason is that even though we have these biomarkers, they're not always sensitive and specific. So for instance, they talk about how low CSF A beta 142 doesn't always reflect beta amyloid deposition in the brain, and may be seen with other brain conditions such as multiple sclerosis or other, if CSF is being collected incorrectly, or if the cutoff that the lab is using is different from other labs. So for all this, again, we don't usually use these in the clinical practice, at least in the United States. In terms of tau and phosphorylated tau, again, these are other measures that we can use for helping to differentiate probable versus more possible Alzheimer's disease. And then there is some data to suggest that combining CSF biomarkers can be helpful, but in practice, it's difficult to differentiate whether, which biomarkers to use in what kind of combinations, and whether or not it can be replicated from one lab to another lab. So there are a bunch of different emerging and future biomarkers that they discuss. I'm not going to go into that into too much detail. Them do focus on proteins. Again, the 2 most common hypotheses of in the brain. So of interest there. To focus on, in the article talk capture individuals who demonstrate markers in their brain, but have not yet neuronal damage. It's really difficult to find if you want to call it a cure, or to stop, reverse, or slow down the disease process. So finding that point where we can really intervene and put our resources, our healthcare resources, is what we're going for right now. That's what we're really aiming for. There are some ethical issues. As just an aside, there are ethical debates about whether or not we should be bringing in patients who don't have any clinical signs or symptoms of Alzheimer's disease or of dementia. So they're really they may be in the preclinical stage. We're putting them through tests, and we're looking for different proteins. We're looking for amyloid, for instance. And if they detect amyloid, what do we tell the patient? We tell them that yes, there's a chance that you might have Alzheimer's disease. Do we know the likelihood? No, we don't know.
Mm-hmm.
Could you develop Alzheimer's disease or dementia even without a demonstration of amyloid in the brain? Of course. So it's sometimes there's a lot of ethical debates about whether or not to enroll individuals who aren't demonstrating any signs of the disease into these studies. On the other hand, we really need these patients because these are the patients that will be able to actually look to see whether or not a possible intervention can help diminish, stop, reverse, or slow down a disease process before neuronal damage has been done. So getting back to the biomarkers, again, it goes through tau PET imaging markers, it goes through MRIs, it goes through some fluid biomarkers, none of which are in clinical use right now, but they're all in development. They're raising, I would say, hopes, as well as, there's a lot of interest in these different biomarkers as the next big biomarker in detecting Alzheimer's disease. And one of the reasons that we want to detect these biomarkers is because then we can develop treatments that are based on these different biomarkers, and we know who to target specifically. So I'm going to move on to biomarkers of frontotemporal dementia. I might refer to this as frontotemporal disease. There actually are, you can look at frontotemporal dementia both clinically and neuropathologically. So if I mix around frontotemporal dementia versus frontotemporal disease, you'll have to forgive me. For all intents and purposes for this particular talk, they're the same. We'll consider them to be the same thing. So after Alzheimer's disease, when it comes to young onset dementia, frontotemporal disease or frontotemporal dementia is the next common cause of dementia. In fact, there are some studies that where frontotemporal dementia approaches a 1-to-1 ratio in terms with young onset dementia, usually individuals below the ages of 60. After the age of 60, frontotemporal dementia really goes down on the list in terms of the likelihood that frontotemporal dementia is the neurodegenerative disease that's at play in somebody's dementia. There are two main clinical syndromes. That includes behavioral variant frontotemporal dementia as well as primary progressive aphasia. Behavioral variant of frontotemporal dementia is one where you see a lot of changes in social function as well as personality. You see executive dysfunction. You see loss of executive control. You see individuals who might be blurting things out publicly without any recognition that what they're doing is probably not considered to be appropriate in social settings. You also see individuals who are making very poor decisions, again, because of lack of executive function. The other type is the primary progressive aphasia, and in this type, you see a lot of decline in language skills. So you don't see as much decline in terms of behavior, although you might see that. You can see, there's, again, you don't necessarily have a pure behavioral variant or pure primary progressive aphasia, but in primary progressive aphasia, you tend to see more of the language decline than the behavioral decline. There are lots of different subtypes. There's also a lot of overlap between frontotemporal dementia and lower motor neuron diseases, motor neuron diseases in general, actually. You see frontotemporal dementia in individuals with ALS, for instance. So that complicates things in terms of biomarkers because it's harder to find a pure biomarker when there's so much overlap neuropathologically between these different diseases. What we're doing is, again, we're looking at the clinical picture and we're trying to figure out, okay, this person clinically seems to have a behavioral variant of frontotemporal dementia. In addition, his onset was before the ages of 60. At that point, I might be thinking about a PET scan to help differentiate between the two. I really want to do as much as I can clinically before I send them in for a test to differentiate, because I know that no biomarker is going to be 100% sensitive or specific, especially with the frontotemporal dementia when there is so much overlap between the different pathologies. About a third of individuals with frontotemporal dementia, and particularly those with behavioral variant frontotemporal dementia, will have a family history that has an autosomal dominant pattern of inheritance. So we always have to ask about family history of dementia on any, in any intake when I'm working up a patient with dementia. So that's one of those dementias where there really is a pretty significant autosomal dominant pattern. But certainly, I would say the majority of the cases that I see are sporadic. They're not autosomal dominant. That knowing that the pattern of frontotemporal dementia, particularly if it's autosomal dominant, does help in terms of finding biomarkers that can be associated with frontotemporal disease. We can look for things such as Pick's disease. We can look for tau. Frontotemporal dementia is a tauopathy. We can look for TDP43 pathology in various in the brain, in CSF. Again, this will help us differentiate, or more specifically, help us say, oh, this is more likely to be frontotemporal dementia than Alzheimer's disease. That being said, while I always get a brain MRI for all causes of dementia, unless with some exceptions, when it comes to frontotemporal dementia, we may not necessarily see brain atrophy on an MRI. Similar that we wouldn't necessarily see atrophy on Alzheimer's disease in somebody with Alzheimer's disease, but it's even more relevant in frontotemporal dementia because the behaviors often are disproportionate to what we're seeing on the MRI. And so it's harder to make a diagnosis based on an imaging, based on, let's say, an MRI for frontotemporal dementia. You really need your clinical acumen to make that diagnosis. You might see atrophy of the frontal regions, the temporal regions in individuals with FTD. As the disease progresses, as they mentioned in this study, there's some involvement of other frontal regions, the striatum, the hippocampi, parietal lobes, temporal lobes, and again, depending on the variant of FTD, you might see different levels or different patterns. You might see more frontal involvement. You might see more temporal involvement. You might see more parietal involvement. Again, there's a whole page on these different patterns. I would say, I mean, I certainly haven't memorized these. I don't really see a point personally to memorize these. If I'm trying to differentiate between, let's say, a specific subtype of primary progressive aphasia, usually that wouldn't affect my management. If I'm thinking about that, I'm going to send them to a specialist, someone who specializes in FTD, whether it's a neurologist or a psychiatrist. I'm usually not getting into those subtle nuances where I'm looking at the differences between semantic versus another type of primary progressive aphasia. I've mentioned before that there is data to suggest that functional imaging can be useful, particularly FDG PET scans, and that has an FDA approval. I'm not going to talk about that because I think I've already talked about that ad nauseum. We're going to move on to CSF, cerebrospinal fluid findings. Unfortunately, there really aren't many CSF biomarkers for FTD, particularly because we can't really use TDP43 to distinguish between various tauopathies, such as frontotemporal dementia and other tauopathies. You see TDP43 in a variety of diseases. Similarly, probably the best use of CSF fluids is to differentiate between FTD and Alzheimer's disease. Again, in that case, we're looking for an Alzheimer's disease type pattern. So looking at A-beta 142 levels that we would expect to see low in an Alzheimer's disease. We're not really looking for an FTD pattern, but rather we're looking to exclude Alzheimer's disease. But in part because of the overlap between Alzheimer's disease and FTD, we don't always see that because there's going to be pathology that's mixed in many patients. So again, then they talk about emerging and future biomarkers. Similar to Alzheimer's disease, these are exciting for many individuals, for researchers. These are new possibilities in terms of avenues for interventions, for different treatments, especially with pharmacological treatments. But as of this point, they're really in the non-clinical state. They're just emerging, and we wouldn't use these clinically. Lastly, we talk about the biomarkers of dementia with Lewy bodies. With dementia with Lewy bodies, it's important to keep in mind that there's a spectrum between dementia with Lewy bodies and Parkinson's disease. They're often thought to be opposite sides of the same coin or opposite ends of the same disorder. Clinically, we use a time frame to differentiate the two. Lewy body dementia consists, what we usually see in the individuals with Lewy body disease are deficits of attention, executive abilities. That's one of the reasons that the MoCA is so useful for Lewy body disease, because it really focuses on visuospatial dysfunction at the very top of the MoCA. So your classic clock drawing, your Trailsby, and your and the cube copying. You'll also see Parkinsonism in individuals with Lewy body dementia. Those usually aren't as severe as individuals with Parkinson's. They tend to arise later or at the same time as the other features of Lewy body disease. That helps us differentiate between Lewy body disease and Parkinson's disease dementia. In terms of the pathology of Lewy body disease, it's an alpha-synucleinopathy, so we're expected to see alpha-synuclein in individuals with Lewy body disease. We may also see dopamine loss. That's one of the reasons that we can use a DAT scan, which is also used in Parkinson's disease patients to help differentiate between Parkinson's disease and secondary Parkinsonism. We often use a DAT scan in those cases. We might use a DAT scan in Lewy body disease. I don't tend to use that. I tend to, again, make that diagnosis clinically. Often you're going to see there's a huge overlap between Alzheimer's disease and dementia with Lewy body disease. I know I'm repeating that, but it really is important to keep in mind that the exception is to see pure Alzheimer's disease, pure Lewy body disease, or pure frontotemporal disease. The norm is to see overlap between these diseases. When it comes to structural brain imaging, individuals with dementia with Lewy bodies often have preserved volume of their temporal lobes compared to those to individuals with Alzheimer's disease. But because we don't really have strict cutoffs, it's hard to say, oh, well, this person's medial temporal lobe is smaller, has atrophied more than another person. Compared to what? If we're looking at serial brain MRIs, okay, maybe we can see something there. But by the time that a patient comes to us, they usually have already progressed to the point that they have clinical symptoms, and we're not going to be looking at serial MRIs to gauge the extent or to differentiate one disease from another. I don't think that Medicare would pay for serial MRIs to help differentiate that. We can use SPECT to differentiate dementia with Lewy body disease versus Alzheimer's disease with some reasonable accuracy. Here in the paper, they states 80% sensitivity and 90% specificity. That's great, but I don't think that SPECT, I'm not sure, please don't quote me on this, but I don't think that SPECT is typically covered by insurance. So it's probably used more in research. If somebody can look that up and somebody wants to jot in and make a quick comment, please, by all means. I'd like to know for myself whether or not SPECT would be paid for by Medicare or by another insurance company. It's also, SPECT tends to be less useful for differentiating dementia with Lewy bodies from other atypical Parkinsonian symptoms, which can show different abnormalities. So we're going to move on to emerging and future biomarkers. Again, like with Alzheimer's disease and frontotemporal disease, these are not used in the clinical. These are not used clinically right now. They're all in very early stages of research. They're exciting in many ways because they hopefully will help us find either cures or different pharmacological interventions that can help slow down, stop, or reverse the disease process. I'm going to close. I think that they have a very nice conclusion here, which I'll focus on as my conclusion as well. First of all, I really want to stress we need to be thinking about, is a biomarker going to change your management clinically? If it's not going to change your management clinically, then why are we getting it? That's the question you really need to be asking. So patients may want it. Okay. But you also have to explain to them, it's your duty to explain that just because we're getting this test doesn't necessarily mean that that it's going to necessarily raise or lower the likelihood that they have a certain type of dementia. And even if it does, will that change our management clinically? If it doesn't, then should we be getting that test? Should we be using healthcare resource dollars for that test? Should we be putting patients through potentially invasive procedures such as a spinal tap? We really need to be thinking about these questions and having these discussions with patients. So also in summary, we do have biomarkers that are incorporated into the diagnostic criteria, such as the 2011 diagnostic criteria of Alzheimer's disease, where biomarkers are used to help differentiate between the likelihood of Alzheimer's disease, such as between probable Alzheimer's disease and possible Alzheimer's disease. We also use biomarkers in research studies to help determine whether or not somebody is fit for a study. If a study is looking at pure Alzheimer's disease, we really want to be as specific as possible, as opposed to in clinically, where being specific may not necessarily change the management. In research, it really will change the management. We need to be able to narrow down the diagnosis as much as possible. Many biomarkers have shown utility on a large level, on a group level, but they don't necessarily that doesn't necessarily correlate or transpose to the individual level. And so we want to keep that in mind as well when we're talking to patients and their families, that these studies, yes, they have clinical utility, but they may not necessarily have clinical utility on the individual basis. And no one biomarker is diagnostic of any condition, again, in part because of the overlap, in part because they have limitations, in part because there aren't strict cutoffs for many of these biomarkers, particularly the CSF fluid studies, but they do help to, they will help us in research, they will help us to come up with new interventions to hopefully change the face of dementia. So, yeah.
Okay, thank you for that. That was actually pretty interesting and a nice review of imaging in general with our dementias. So there's no questions. There is one comment from one of our members that said, I met with neuroradiologists to report specific findings on MRI for cognitive evaluation, which I always mention while ordering. However, they do not do volumetric analysis for hippocampi nor assess the extent of vascular disease.
Yeah, so that's, I should probably mention that is there aren't too many locations where you'll have neuroradiologists who will do that. They tend to be in research-oriented, oh, you're welcome. They tend to be in research, in academic medical centers that are focusing on Alzheimer's disease. Often radiologists are involved in different research studies. So yeah, it's not that, you're not commonly going to find neuroradiologists who will do volumetric testing on the hippocampi. Another reason why we don't focus on that in terms of the diagnosis.
Okay, well, thanks for that clarification.
Yeah.
And thank you again for going over this article. Remember, guys, we just have 3 more articles after tonight. And if you complete all the Journal Club's articles on the American Physician Institute website, you can get a total of up to 10.5 free CME hours. So if you haven't signed up, you can sign up anytime. And once you sign up, you have a full year to complete them. So you're going to get 0.25 credits per article. And there's 42 articles, which is a lot. So all right. Well, thanks again. And we'll see you guys on Wednesday.
All right. It was a pleasure.
Okay. Take care. Bye.
You too.